Today we are going to be learning about the topic organophosphate poisoning. It is a very important topic and frequently asked question in pharmacology, and it is also very important in clinical aspect also, and it is very interesting. So let us start learning with this. Uh, this is the nerve ending. These are some of the basic things that you need to know. This is the nerve ending, and we all know from the nerve endings, a neurotransmitter known as acetylcholine is released. This acetylcholine is degraded with the help of an enzyme known as acetylcholine esterase enzyme. This acetylcholine esterase enzyme, what it does, it degrades acetylcholine, and therefore the uptake of acetylcholine into the nerve is possible. Now, if we introduce drugs known as anticholine esterases, what these drugs do is that they will bind to acetylcholine esterase enzyme and they will inactivate the enzyme. Now, because of which the function of this enzyme, the function of acetylcholine esterase enzyme is hampered. Therefore, there is no degradation of acetylcholine, because of which there is increase in acetylcholine and symptoms are seen. The symptoms that occur due to increase in acetylcholine can be memorized with the help of an enzyme, with the help of a mnemonic known as dumbbells. So where D stands for diarrhea, U stands for urination, M stands for meiosis, and B stands for bradycardia. Another B stands for bronchoconstriction. E stands for excess HCl. L stands for lacrimation, and S stands for salivation. These drugs, anticholine esterases, are of two types. You have reversible anticholine esterases, irreversible anticholine esterases. Under irreversible, examples are organophosphates and carbamates, and in reversible, we have two types, that is tertiary and quaternary. In tertiary, you have physostigmine, and in quaternary, you have neostigmine. So, about the reversible anticholine esterases, we will be learning in another video, but for now, we will concentrate on irreversible anticholine esterases. So, look at this question. A 42-year-old farmer was brought to casualty with symptoms of irritation of eyes, lacrimation, excessive salivation, burning of vision, breathlessness, involuntary defecation, and urination. Based on these symptoms, a physician made a diagnosis of organophosphate poisoning. Right. So, based on these symptoms, even you can tell that it is a case of organophosphate poisoning. Discuss the management of organophosphate poisoning. So, organophosphate poisoning comes under the heading of irreversible anticholine esterases. Examples of irreversible anticholine esterases are carbamates and organophosphates. Carbamates example is carbaryl, and then organophosphates can be TIC20 and Marthion. Organophosphate poisoning is usually seen in farmers as a case of, like, it can be a suicidal case, it can be a homicidal case, it can be an accidental case. These substances are usually present in insecticides and pesticides. So any case if you are in an OPD and if a farmer comes in with all the symptoms such as excessive salivation, lacrimation, breathlessness, bradycardia, excess HCl production, and all the symptoms that we are urination in dumbbells, all the features that are seen in dumbbells, then you can conclude. And if there is a history that the farmer by accidentally he took insecticides or inhaled insecticides a lot, you can conclude that it is a case of organophosphate poisoning, and it is an emergency case. Death can also occur because of respiratory failure, so it is an emergency case. Now we are going to be looking at how the mechanism of poisoning actually takes place. So this is the enzyme, that is choline esterase enzyme, that I had drawn there. It has two sides. It has an anionic site and it has an esteratic site. So normally, how does this enzyme work? Normally what happens is acetylcholine, the neurotransmitter, comes and it binds to the anionic site. You remember from A to A. So acetylcholine will bind to the anionic site. And this esteratic site, it will help in the breakdown of acetylcholine into acetyl plus choline. Therefore, the degradation of acetylcholine is possible through this way. Now, because of when we introduce anticholine esterases, what they do is, for example, organophosphate. What does it do? It will come and it will bind to the esteratic site. Organophosphates will come and bind to the esteratic site, due to which the breakdown of this acetylcholine is not possible, right? And then you have tacrin and idrophonium. These are drugs that are irreversible anticholine esterases. So these will come and bind to your anionic site. Again, because of which acetylcholine cannot bind there, due to which there is increase in acetylcholine. And then you have carbamates. Carbamates, what do? They bind to both anionic as well as esteric site. Obviously, so all because of all these three, what is happening? Acetylcholine is either not getting placed to bind to the anionic site, or it is not getting broken down, because of which there is increase in excessive acetylcholine, and therefore we see symptoms such as dumbbells. We see symptoms known as dumbbells, right? Now, organophosphate poisoning is more dangerous if aging of the enzyme takes place. Now, what is aging of enzyme? If organophosphate poisoning continues for a long period of time, then the organic part of the organophosphate will separate and all the 5 bonds of phosphate will bind to the enzyme. As you can see over here, this is how I've drawn organophosphate. Everybody knows phosphate has 5 points, right? 5 bonds, right? So 2 of them are bound to the enzyme, 3 are bound to this organic group. Now, if this organophosphate poisoning continues for a very long period of time, passively, what will happen is this organic group will separate out, and this phosphate will bind. All the 5 bonds are bound to the enzyme. Now, this enzyme is irreversibly blocked. We can never reactivate this enzyme, so it is very dangerous. Aging of the enzyme is very dangerous. Now we have learnt about the symptoms, we have learnt about the mechanism. Now we are going to see the treatment. How are we going to treat organophosphate poisoning as well as carbamate poisoning? In organophosphate poisoning, in both of them, the first drug of choice will be IV atropine. We have to give IV atropine. What is atropine? Atropine is an anticholinergic drug which will go and it will block your M receptors, due to which the action of acetylcholine is not seen. Okay, we will learn more about atropine coming up. And then in organophosphate poisoning, what are you going to do? We are going to add on a drug known as oximes. And over here in carbamate poisoning, we are not going to do it. It is contraindicated. Oximes are contraindicated in carbamate poisoning. In OB poisoning as well as carbamate poisoning, the drug of choice is IV atropine. Later, what is going to happen? Later, we have to add oximes in organophosphate poisoning, and in carbamate poisoning, it is contraindicated. So, oximes reactivate. What are oximes? What does oximes actually do? Oximes reactivate CHG enzyme by binding to the anionic site and removing organophosphates that are present on the esteric site. So look at this. Oximes, what it will do? It will go and it will bind to anionic site of the enzyme, and organophosphates are already present on the esteric site. It will bind to this and both of them will together go out. So therefore there is reactivation of this enzyme. That is the normal function of this enzyme can take place. Therefore we said oximes help in the reactivation of the enzyme. But this cannot be done in carbamate poisoning. Why? Can you tell me why? Because carbamate, what it does, it binds to both of them. Carbamates bind to anionic site as well as esteric site. So there is no place for oximes to come and bind over here. Therefore, oximes are not helpful in carbamate poisoning. This is a picture I have drawn again so that you recall that organophosphates bind to the esteric site, taccharin, hydrophonium bind to the anionic site, and carbamates bind to both anionic site as well as esteric site. So examples of oximes are you have palindroxime, that is PAM. You remember PAM and DAM. PAM stands for palindroxime and DAM stands for diacyl monoxide. So the second drug that we have to talk about is atropine. It is an anticholinergic drug that blocks muscarinic receptors. Told you, it is an anticholinergic that blocks muscarinic receptors. It is the overall drug of choice. It is a life-saving drug. When it blocks your muscarinic receptors, M receptors, the action of acetylcholine cannot be expressed. So therefore, you will get, what are the symptoms you will see? You will actually, when you give atropine to the patient, you will be able to observe whatever you saw, the dumbbells, the symptoms which we saw, the opposite of that. Like in dumbbells, D stands for diarrhea. You will be able to see constipation. In U stands for urination. You will be able to see urinary retention when you give atropine. M stands for meiosis, and you will be able to see mydriasis of the eye in the patient. Right. B stands for bradycardia. You will be able to see tachycardia. You will be able to see tachycardia in the patient. So we have to give IV atropine. How much? 2 milligram per kg repetitive injection until signs of atropinization are seen. I just now told you what are the signs of atropinization. It is all Opposite of dumbbells are nothing but signs of atropinization. Example, mydriasis, tachycardia, constipation. How will you check? Mydriasis can be seen with the eyes, you can see it in the patient. And then tachycardia can be checked by pulse rate. Constipation, you will be able to hear reduced bowel movements. And then there's dryness of respiratory tract or bronchial secretion. This sign is the definitive sign of atropinization. That is when you know that you have to stop giving atropine to the patient. So this is how we manage a patient when he comes to the OPD with OP poisoning, and you save the life of that patient. Chronic OP poisoning, this is usually seen in industrial workers in insecticides and pesticide factories. It is also seen in long term. It is nothing but long term low exposure for many years. There is permanent and irreversible damage. Irreversible damage. There is no cure for chronic OP poisoning. So this was all about organophosphate poisoning. Thank you for watching. If you guys feel thank you for watching.